Hi, my name is Abdul Kouanda. I'm a third-year internal medicine resident at UCSF Medical Center and soon-to-be first-year GI fellow.
Hello, my name is Luke John Day, and I'm an associate professor of clinical medicine at the University of California, San Francisco.
We're here today to talk to you about our study entitled Urgent Colonoscopy in Patients with Lower Gastrointestinal Bleeding, a systematic review and meta-analysis. First, I will talk to you about why we decided to pursue this study. Lower gastrointestinal bleeding is a common cause of morbidity and mortality that has been increasing in incidence over the decades. Lower gastrointestinal bleeding also portends a worse prognosis in the elderly age group. There have been a number of studies over the years that have looked at the matter of urgent colonoscopy improving outcomes in lower gastrointestinal bleeding. However, there is no clear consensus as to the optimal timing of colonoscopy. Given this lingering question in the literature, we've decided to pursue a meta-analysis combining all available data in order to answer this question. Additionally, in this age of healthcare reform, we're continually seeking ways to provide concise, cost-effective care.
For our study, we conducted a systematic review and meta-analysis of the literature that included urgent and elective colonoscopy for patients who were admitted to the hospital for a lower gastrointestinal bleeding. In our literature review, we included 12 studies, of which the majority of them were cohort studies. In our elective colonoscopy arm, over 14,000 patients were included, whereas in the urgent colonoscopy arm, over 10,000 patients were included. We looked at a number of significant clinical outcomes as they relate to lower GI bleeding. First, we looked at bleeding source localization, rebleeding rates, use of therapeutic interventions, adverse event rate, rate of blood transfusions, mortality, length of hospital stay, and mean hospital cost. For our statistical analyses, we performed two significant analyses. First, we did pooled rates for selected outcomes, and secondly, we calculated rate ratios for selected comparison groups. Lastly, in order to increase statistical robustness and reduce study heterogeneity, we performed a number of subgroup analyses.
Now, to discuss the results of our study. Overall, urgent colonoscopy does not appear to alter important clinical outcomes. Specifically, there was no difference in mortality, adverse events, rebleeding rates, source localization, or transfusion rates. We did find an increased use of therapy in patients undergoing urgent colonoscopy. We believe this likely represents a selection bias. Critically ill patients seem more likely to undergo urgent colonoscopy, and endoscopists may be more likely to perform therapy in these patients. Additionally, urgent colonoscopy appears to be safe and well tolerated, as there was no difference in mortality and adverse events between the two groups.
There were a number of important findings from our subgroup analyses as well. First, when we restricted the analyses only to retrospective cohort studies, we found that there was an increased use of endoscopic therapy, and there was a decrease in the rate of blood transfusions in patients who underwent urgent colonoscopy. Second, when we restricted the studies to only prospective studies, we found that there was no difference in outcomes between urgent or elective colonoscopy. Lastly, we found that there was a trend towards a decrease in hospitalization time for patients in the urgent colonoscopy group. However, there was no difference in overall hospital costs between the urgent and elective colonoscopy group. In summary, we performed a systematic review and meta-analysis of all available literature looking at elective versus urgent colonoscopy in patients who were hospitalized with lower GI bleeding. We found that urgent colonoscopy is a safe procedure, however, did not alter significant clinical outcomes. More work is definitely needed in this area. First, more studies need to be conducted to try to identify which subset of patients may actually truly benefit from earlier intervention. Two, cost-effective analysis studies need to be conducted. And third, larger randomized clinical controlled trials also need to be conducted to really determine whether or not there is an overall benefit to performing urgent colonoscopy in this clinical setting.